Welcome, and thank you for joining us today for the International NASH Day panel on NASH and Metabolic Syndrome. My name is Dennis Cryer, and I will be your moderator today. We are one of 6 thought leader webinars being conducted as part of the recognition of International NASH Day, an initiative of the Global Liver Institute and 80 partners in 25 countries. This year celebrated as a virtual multi-platform experience to raise awareness of NAFLD, non-alcoholic fatty liver disease, and NASH, non-alcoholic steatohepatitis, and to spark a global movement to actions to improve the lives of people at risk for and living with these conditions. Please visit our website at www.globalliver.org and follow us on Twitter, Facebook, and Instagram using the hashtag #NASHDay. I want to give a special thank you to the AASLD, the American Association for the Study of Liver Diseases, and EASL, the European Association for the Study of Liver, for endorsing the IND, and to our corporate sponsors. We very much appreciate all of their support. Now I would like to introduce our august panel for the topic of NASH and Metabolic Syndrome. Our speakers today will be Manal Abdelmalek, Professor of Medicine at Duke University in Durham, North Carolina. Dr. Laz Ude Eze, who's the Executive Director of Lafiya Wealth Initiative in Abuja, Nigeria. And Professor Sven Francque, who's Professor of Medicine at the University of Antwerp in Belgium. Now, I want to start off by giving a little bit of my own background and how I got into the area of metabolic syndrome and my own interest in getting involved in trying to help out with these efforts. My training was in molecular genetics, had little to do with metabolic syndrome. Metabolic syndrome didn't exist in those years. But then I went on for training, subspecialty training eventually in genetics and metabolic diseases, during which time I began studying the secretion of hepatic lipoproteins and their turnover in cells in humans as they applied to atherosclerosis. During the time of that research, and subsequently, as I went into R&D on drug development, the field of metabolic syndrome began to be recognized. It was first, I believe, in 1988 that Dr. Gerald Reaven, professor of medicine at Stanford, suggested that there was some sort of association of these many factors. There were only about 3 when he first started that he really tightly put together, that he called metabolic syndrome, and he felt that they were all related through insulin resistance. Over the years, that concept evolved and expanded to include a variety of other factors, such that now there's a considerable list, an appreciation that not only the early recognition, which was that this tended to lead to heart disease, early heart disease, that had been unrecognized, but also that it has a variety of other potential outcomes, not the least of which are NAFLD and NASH. So many years later, that was 1988, many years later, we have had, even in the very recent years, the convergence of multiple disciplines, several of which are represented today, and in others of our presentations, from metabolic syndrome to these very fundamental liver issues. Over those years, I began to have a an international view, I should say, of this issue, being involved in meetings and participating with groups such as the American Heart Association, American Diabetes Association, the International Diabetes Federation, the European Society of Cardiology, European Atherosclerosis Society, and European Association for the Study of Diabetes, as well as the World Heart Fund, excuse me. All of these were coming to this realization at about the same time. And it's very gratifying to me now to see how we're really understanding better on a more metabolic pathway and molecular level, how this all comes together in some serious and troubling ways in our society today. I'd like at this point to turn the microphone over to each of our panelists today. And we will start with Dr. Abdelmalek, and I'll let you talk a little bit about your perspective, your work in NASH, what some of the issues are, and some of the challenges that you are facing, and how it may be different for you here in the USA than for others elsewhere in the world.
So I've been in the space of NASH and NASH-related research for over 2 decades now, and it is very gratifying to see the advancements that have been made both in science and in clinical research in targeting this disease. This condition affects nearly 25 to 30% of the global population. It certainly affects about 25 to 30% of US Americans, adults. And it goes hand in hand with the metabolic syndrome, as you've already stated: obesity, diabetes, high cholesterol, hypertension, weight gain. And so we've come to learn that this is clearly a multi-system disease. And while the majority of patients really don't have negative clinical outcomes, those patients that develop non-alcoholic steatohepatitis are at risk for disease progression. And through various stages of fibrosis, ultimately progressing to cirrhosis. And with that can come the increased risk of liver cancer or need for liver transplantation. I think that the greatest challenge for us in this field is, given the very large population at risk, identifying very readily and targeting appropriately those patients whom are at risk for disease progression and for whom the emerging armamentarium of therapies that is becoming available or will become available to us, how to tailor the best treatment plans accordingly to the patients who are going to have the greatest benefit from therapies targeting metabolism and specifically targeting NASH and hepatic fibrosis.
Thank you, Dr. Abdelmalek. Dr. Eze, maybe you can tell us a little bit from your perspective, which I understand to be more of a public health perspective in a very different part of the world. What some of the, not only give us a little bit of your background, how you got into that, but also some of the challenges that you face that may be somewhat unique to your location. Thanks.
Thank you very much. I'm Laz Ude Eze. I'm a public health physician with over 15 years experience in health advocacy. I've worked in Nigeria and a couple of years in the United States when I did my postgraduate in health policy and management in the University of Kentucky, and also did some work in Togo. On NASH, over the years, I've been leading a lot of health advocacy here in Nigeria and a whole lot of public health issues. Of course, infectious diseases are very dominant here, and also non-communicable diseases, the incidence and the prevalence has also been on the rise. So we have a kind of double epidemic kind of thing to deal with. I've had conversation with clinicians, endocrinologists, here in Abuja and some parts of the country to kind of get a glimpse of their experience with patients with type 2 diabetes mellitus, metabolic syndrome, obesity, and all that. And one of the key challenges we have in some parts of the country, especially in the rural areas, is non-availability of diagnostic equipment to kind of screen these patients. So you have a number of patients with these health conditions that get to seek care like 4 or 5 hours away from their location. And of course, after the initial evaluations, they have to go back to the primary location where they will be taking their drugs. And, you know, so in terms of following up with the progression of the disease, there might be a whole lot of challenges. And also healthcare expenditure in Nigeria is 70% out of pocket. Less than 5% of Nigerians have health insurance. So a lot of persons cannot afford out-of-pocket payment for ultrasonography, MRI, CT scan, you know, to kind of screen, do some of the liver function tests to diagnose NASH. So it's a huge challenge from the aspect of access to care. It's a huge challenge also from the aspect of public awareness, and also that screenings for routine screening is not very much available. People have to pay out of pocket. But the good news is there's an ongoing effort to get legislation around this. And Lafiya Wealth Initiative, which I'm the acting executive director at the moment, is doing a whole lot of that, working with experts in this field to get a legislation to support, you know, routine screening to kind of pick up metabolic syndrome in good time, you know, and give way for proper diagnosis and management.
Thank you. Screening is a huge challenge, I'm sure, for everyone around the world, and maybe you can talk a little bit more about that a little bit later. Dr. Francque, do you want to tell us a little bit about your background, how you got to the NASH world, and the situations and challenges that you find in Europe?
Yes, thank you. Well, I'm also about 20 years now in the field of NAFLD, and with the main interest in trying to contribute to our understanding of how this disease originates, what the pathophysiology of this disease is. And we're conducting both basic research and clinical research in that regard, because that's the fundamental knowledge we need to go to the management and the treatment of this disease. And there are, of course, many challenges in this disease, but one of the things that puzzles me most is the close relation with what you talked about, the metabolic syndrome. So we understand now that in the vast majority of the patients, there's a very close link with that metabolic syndrome, or at least components of it, being it the insulin resistance, the dysfunctional adipose tissue, and so on. And what is very important is that we need to understand that the liver in NAFLD in this context is not just a consequence of the metabolic syndrome. The liver is one of the drivers of this constellation of metabolic diseases, and really participates in the long-term outcomes, not just in terms of liver disease, but also in terms of diabetes and cardiovascular disease. So that very close intertanglement between the liver and all these other diseases is fundamental in our understanding of how we should approach this disease and how we should manage this disease, and not just about the pharmacological therapy. Therefore, it's particularly important. But for the whole approach, we really need to have that more global, holistic approach of the metabolic syndrome, or however you want to call it, and not just focus it on it as just the liver disease. It's really embedded in that large disease spectrum that we need to take into account. And so a particular challenge in the management is really to have all these different specialties and layers of healthcare being united in the management of this disease, and not everybody separated and fragmented from his own point of view or from his own specialty. And that's a particular challenge, I think, and not just in Europe, but worldwide.
Absolutely. I'm wondering, indeed, our European panelists and our American panelists are both in academic centers, and I would guess from my own early academic days, it may be fairly feasible to coordinate all those things within a center like yours. Firstly, either one of you, is that the case in your universities? And number two, what about in the community? Outside of the University of Antwerp, outside of Duke University, across the country, for what I call free-range patients that aren't lucky enough to be part of to be followed by an academic system. Dr. Abdelmalek, I'm sorry.
So there is, I've come to learn over the years that caring for patients with complex multi-system and metabolic syndrome related diseases does take a level of interdisciplinary collaboration. And I'm very fortunate at a big academic center to be able to collaborate and care for my patients in partnership with an endocrinologist who helps me manage lipids or diabetes, a cardiologist who can help me offset the risk of cardiovascular disease, to have access to radiologists readily who can quantify and quantitate fat, and to be able to have in my own practice the ability to do non-invasive testing using instruments such as a fiber scan, stiffness measures of the liver, and as a big academic center to have access to and the ability to do clinical trials that will allow us to evaluate new therapies that are going through various stages of development. Also at my center, I have the privilege and the honor to see many patients who have been referred to me by primary care physicians for evaluation of elevated liver enzymes, for whom we grow to understand that their diagnosis is NASH, or that are also referred with the specific intent to get access to new and emerging therapies. And I also have access to bariatric surgeons who can help me tackle not only the complications of obesity and diabetes, but potentially even complications of fatty liver disease in patients for whom such an option has been a consideration. Not to say that this couldn't be done in community-based practices, but I have the good fortune of having such patients, providers in my immediate larger academic practice.
And Dr. Francque, what's the experience in Europe? Again, academic center versus patients that don't have that access, that are cared for elsewhere.
Well, of course, as an academic center with a long-standing interest in it, we have been able over the years to build up a multidisciplinary approach, including all the different treatment modalities that Dr. Abdelmalek also discussed. So that's even in our situation, I think we are not there yet to have a really complete, very integrated multidisciplinary approach, although we made a lot of progress in the past years. We were also lucky, I think, to be able in Belgium to produce a guideline with many scientific stakeholders, not just from the liver perspective, but from a global perspective, different specialties, also including general practitioners and some patients. So that's a good thing. You probably know also that on the European level, there is a guideline which is produced by the Liver Society, the Diabetes Society, and the Obesity Society. So that's an example of multidisciplinary collaboration and coordination. But outside some examples, I think in the vast majority of the centers, and especially in the community, it's not there yet. The problem of the awareness is still a huge challenge we face, and also global organization of healthcare, although it's my impression that it is changing, is still very focused on curing or trying to treat an established disease, and still does not invest enough in prevention or early treatment. So there's still, I think, a long way to go. Awareness is growing, but we are not there yet. I think there's still a lot of work to do.
Well, we here in Washington, D.C. can appreciate the challenges if you're not in the midst or of the academic health center to receive your care and have challenges in spite of, you know, my fairly sophisticated background, trying to put things together. There are few people that are interested or willing to do that. And a part of it in this country has to do with reimbursement. You know, can't get paid for coordinating care. Well, terribly important, nevertheless. And so that it's a challenge even with access to some excellent centers. Now, Dr. Eze, what's your situation in Nigeria? You're not in an academic center, so and your resources may be less than our other panelists. Tell us about that.
Yes, we have a lot of challenges as a civil society organization, trying to create awareness, not just among the general population, but also for general practitioners who are not working in tertiary hospitals that is a bit more equipped to carry out the diagnosis and management of NASH. So as the civil society, sometimes we have funding constraints in going to different parts of the country and having to break down our messages in different languages that is very much understandable to the people. One of the things that Lafiya Wealth Initiative seeks to do is to kind of promote the behavioral change communication, you know, especially as it has to do with prevention, the risk factors to create, and good enough, you know, the behaviors that is required to prevent NASH is also required to prevent a whole lot of other non-communicable diseases. So we hope to keep collaborating with partners like Global Liver Institute, as well as other local partners. We are talking with some research institutions here in Abuja, especially the University of Abuja Teaching Hospital, with some specialists there to kind of ramp up efforts to create more awareness around this. We've also produced the pamphlet, the message that, you know, Global Liver Institute shared. We're going to be distributing these to some treatment centers to create more awareness around NASH. So, but definitely as a civil society, non-governmental organization, most of the challenges we have has to do with funding for many of the activities we plan to carry out.
With no approved drug therapies in most countries to treat NASH, it means that lifestyle, either prevention or using lifestyle to try to reverse the process is what we've got once we do identify the patients. To what degree, I guess particularly where it's likely to be more common in Europe and the US, does the treatment of patients with statins or treatment of type 2 diabetes or prediabetes to push hemoglobin A1C down, to what degree does that, do you think, help in terms of the ultimate management, long-term management of patients?
It will help a great deal, but in Nigeria and many parts of Africa, a key challenge we do have is late presentation. A lot of persons with diabetes, type 2 diabetes, with metabolic syndrome and other forms of non-communicable diseases, they get to present mostly in advanced stage at a period that there are minimal clinical interventions you could do to stop the progression of the disease. So, and that also has to do with the overall state of the health system. We're pushing strongly for universal health coverage, and we are pushing strongly for legislations and policies that will make testing for blood glucose, testing for lipid profiles, and all that to be free or highly subsidized, so that a lot of persons will have the opportunity to check for their blood glucose and be able to identify when they are pre-diabetes stage, and of course, perhaps if they already have diabetes. That will help a whole lot for early detection, early treatment, and of course, prevention of NASH, which is a potential complication of those metabolic health conditions.
Any other thoughts, Dr. Abdelmalek, on the treatment of some of these other aspects of metabolic syndrome and the impact on NASH and how it may be useful, or to the extent to which it is occurring in the United States?
So I think there's broad agreement that the foundation of the treatment of NASH, irrespective of whether somebody has simple fat in the liver or NASH even with fibrosis, the foundation is lifestyle modification, physical activity, and altered dietary habits with the avoidance of high fat diets, avoidance of high fructose diets. In fact, we want to avoid the Western style US diet, and I suspect those in Nigeria and those in European countries probably have healthier diets potentially, but one that is enriched mostly with protein, fresh fruits, fresh vegetables, and routine physical activity with the ultimate goal of weight loss. Weight loss anywhere between 5 to 10%, but there is data suggesting that physical activity, even in the absence of weight loss, can improve NAFLD and NASH. The role of statins in optimizing complications of metabolic syndrome is very important for our patients. And while we don't have an exorbitant amount of data on use of statins as a treatment for NASH, we have to remember that, first of all, there's no data to say that use of statins is unsafe in patients with NASH. As a matter of fact, the data suggests that they are very safe to use in patients with NASH and in patients with metabolic syndrome. And so statins, when indicated, should be readily used because it still remains that cardiovascular morbidity and mortality is the leading cause of death in patients with fatty liver disease. And so use of statins should be utilized not only to decrease their cardiovascular risks, but potentially also to decrease metabolic risk factors for NASH, hypercholesterolemia, and hyperlipidemia. There is evolving data to suggest that improving diabetic control and even resolution and improvement of glycemic control or diabetes may be helpful, and thus anti-metabolic medications have been very important and interesting targets for the treatment of NASH.
I think those are very good points, so that incidentally, in treating some of these other features of the metabolic syndrome patient who may be at risk or have NASH, some of the therapies that they routinely would get in the US are probably rather helpful.
That's exactly right. So I look at each and every risk factor my patients may have If they have poor diets, I refine them. If they are sedentary, we work on exercise. If they have diabetes, we treat it accordingly. If they have high cholesterol, we will treat that. High blood pressure, we'll work on that. So treating each and every potential consequence and risk factor or characteristic of metabolic syndrome is essential in the comprehensive care of a patient with NASH. And I will utilize those therapies and those approaches readily in the absence of an alternative FDA-approved therapy.
Dr. Eze mentioned that often, and this is true, I think, worldwide, often patients with NASH don't come to the attention of the gastroenterologist or the hepatologist, if there are any around, until very late in their disease. That's a problem. If their liver enzymes are elevated, it may be time to put them on the transplant list after all. Dr. Abdelmalek mentioned the need for and the development of non-invasive tests to be able to make better earlier diagnoses and to follow progression or regression of the disease. And Dr. Francque, I wonder if you could expand on that a little bit. Just historically, liver biopsy was always considered, and still by many, I believe, to be the gold standard. And yet we realize that when you're thinking about pathophysiology and thinking at the cellular level, a liver biopsy is taking, is telling you what's happening in a very, very small portion of the liver. So it's not what you would normally consider a gold standard. It's what we had for a long time, not very good. And what are some of the newer technologies, non-invasive, that are being developed that have promise and that might be able to be expanded for wide use around the world? Dr. Francque, thoughts?
Well, I agree that the liver biopsy is, as many other diagnostic tools we have, it's not perfect. And it gives you a lot of information, and it's probably still the best standard we have if we want to have an accurate view on all the different aspects of the disease. But probably, first of all, it's still a procedure with risk and limitations, as you just mentioned. It's although very informative, it's not perfect. And second, we can have some alternatives that can already help us quite a long way down the road to have the most important information about this disease. So probably the place of the biopsy in our diagnostic armamentarium will change in the future. I think it's still a very rich source of information, but we need other tools for the many patients we have. The one perfect test to give us all the information that the biopsy can provide you with does probably not exist. We will need a combination of tests. And we have already learned quite a lot how to work with some, let's say, routinely available blood tests combined with some clinical markers can already give you quite some information. If you then have an ultrasound combined with a measurement of the liver stiffness, so a quality of the liver tissue, which is more global than of course, a small sample of the liver biopsy, and you combine this information, you have already an interesting picture that can help you select patients or tell patients, okay, we have an argument that probably your liver is sick, or you can reassure them. And that's probably what is the most important point where we are today. Many of these tests help us to rule out the presence of significant liver lesions. So they are very helpful at this time point, especially if you combine them and you have several, let's say, rather easy tests that tell you the same message. Okay, here you have very little arguments for a more advanced liver disease. That's probably then very close to the truth, and you can use that to reassure the patients and also guide you in how to further monitor these patients. The other way around, tools to really have an accurate diagnosis of disease that then is really present, there's still a long way to go. There are huge efforts going on. both in terms of what we then call biomarkers based on blood tests or on imaging, to have more the positive diagnosis of the different liver lesions that really matter to us in trying to decide with the patients what the optimal management is. But we're still in the phase of validating many of these tools, discovering many of these tools. So I think at this time point, we have already some tools that can help us, especially to rule out the presence of significant liver lesions. And that's a very important thing, because and luckily enough, for quite a substantial proportion of the patients, there is not yet very advanced liver disease. So that is very helpful, but we need still to work on tools that can give us some accurate diagnosis of different aspects of the disease, and especially in the assessment of how patients can be monitored during their management, not only for pharmacological treatment, but for their management in general. So progress has been made, but we're not there yet for all the aspects of the diagnosis and the monitoring of the patients.
One thought when I go back to the gold standard, as it were, of liver biopsy is that I don't believe anywhere in the world there are enough hepatologists to biopsy all the patients that are at high risk for having NASH. So you have to have other approaches and other physicians that can do that. The primary care docs, community physicians. Now, to what extent do you feel that they can manage patients and their NASH if those physicians do not have some of these non-invasive technologies, ELF, fluoroscan, fibroscan, excuse me, or liver multiscan? In primary care, Dr. Abdelmalek, what do you think in the US is the option? That's what most people see a primary care doc or an OBGYN until they're very sick, often late in life.
You know, one doesn't have to be a hepatologist and be equipped with a lot of fancy tools by which to risk stratify patients. Non-alcoholic steatohepatitis is a diagnosis of exclusion. And first and foremost, it's essential that a primary care provider exclude the use of alcohol, exclude common conditions such as hemochromatosis as a cause for elevated liver enzymes, use serologic markers to exclude immune conditions. And after that, a patient with metabolic syndrome who has elevation of liver aminotransferases can be effectively risk stratified in so much as well as a biomarker if you stack the potential risks. For example, a patient who's older than the age of 50 with diabetes or 3 or more risk factors of metabolic syndrome is already a patient who is at higher risk for NASH, and particularly NASH with chronic elevation of liver enzymes. If there's a family history of unexplained cirrhosis or a family history of unexplained liver cancer, certainly that's a patient who's going to be at higher risk for NASH with fibrosis or be at increased risk for disease progression to NASH. And there are clinical mathematical models, as Dr. Francque has alluded to, the NAFLD fibrosis score or the simple utilization of a FIB-4 score, that in combination with a liver ultrasound revealing a bright hyperechoic liver, the presence of elevated liver enzymes, and the phenotypic risk factors that I've alluded to of a patient can help a physician discern high risk versus low risk and assess the need for a referral.
Just Dr. Eze, I wanted to have your thoughts on this as well, because again, you're seeing it from a different, little different vantage point.
Yes, talking about the diagnosis and the capacity of health workers, especially primary care physicians. Here in Nigeria, the primary healthcare system handles most of the very common health conditions, which are largely infectious. There is minimal experience when it comes to the management of non-communicable diseases, and that's largely due to absence of diagnostic tools. If they are unable to check for elevated blood glucose, unable to check the lipid profile, unable to even carry out ultrasonography in many of the primary healthcare facilities, especially those who are outside the cities, it's obvious that they won't be able to even make the exclusion that is required to suspect NASH in the first place. So, but having made that point, there's also challenges around the capacity to do liver biopsy. The number of pathologists is grossly inadequate. The facilities where this can be done are also not very many. So, and even healthcare workers who have the skills to do it are also not that much, because it's a somewhat invasive procedure, and not a whole lot of patients will be open to giving consent for this to be carried out. Neither would one have the equipment to manage the potential complications of this. So, but what is mostly used here is the ultrasound, abdominal ultrasound, and CT abdomen, which could give those signs of fatty liver disease, and of course ruling out history of alcohol and also other potential health conditions. But here in Nigeria, we use more of ultrasound, to kind of check the architecture of the liver parenchyma. Liver biopsy is not very common. It's done in situations where it is absolutely necessary, but not where you're just suspecting of NASH, because of the cost of doing it, because of inadequate manpower to do it, and also because of lack of capacity to manage potential complications that may arise from the procedure.
Thank you. Now, I'd like to ask each of you just briefly as we wrap up, if you have one specific takeaway point that you would like to give to our audience based on your own experience and some of the things that you've said to this point today. Maybe I'll start with Dr. Francque, if you don't mind.
Well, I think one of the important things is to spread the word and help us to increase the awareness of this disease amongst all people that are involved, patient and healthcare providers. And the second thing is that we really need to look at this as part of a metabolic systemic disease, and that should guide the whole management of the patients.
And Dr. Abdelmalek, a takeaway from your perspective?
Well, a takeaway, I think we should be very excited about the future of liver disease in general, but also non-alcoholic fatty liver disease. From the onset of the work that was done by the NASH CRN over the past 15 years, through the very exciting landscape that we've seen with drug development and compounds approaching FDA approval, we've learned a lot, and we have a lot to be encouraged about. The evolving landscape of biomarker development and imaging, both and blood-based biomarkers, I am very hopeful that in the future we'll be able to detect patients more readily and gauge therapies more easily. I think one of the big obstacles that still sits in front of us is broader-based education and access to address the needs of a very large population at risk, and to do so with better accuracy and thoughtfulness about cost effectiveness. When we deal with millions and millions of people affected, we really need to be very strategic in our approach to diagnosis, evaluation and treatment.
And Dr. Eze, last but not least, what's a final takeaway that you'd like to share with our audience today?
Yes, I think it's very important that it gives one's hope going forward, the awareness that is being created around NASH and of course other forms of liver diseases. And from the public health perspective, we think more of primary prevention. Given that there is no pharmaceutical medication at this moment that you could easily take and it takes care of NASH, the best approach is promoting healthy lifestyles, good nutrition, regular exercise, and of course early diagnosis, training for healthcare workers, and of course the overall health system strengthening to be able to handle NASH as well as other non-communicable diseases. So with the International NASH Day that just started a couple of years, I believe there is so much awareness that has come on this and even make clinicians to be able to look out more for this, and also public health experts to do more in terms of education. I'm really excited about the future around it.
Thanks very much. I want to thank all three of our panelists today, Dr. Abdelmalek from the United States, Dr. Eze from Nigeria, Dr. Francque from Belgium, and I'd like to thank you, our viewers. We encourage you to check out the other IND panels. Information for these and all of our International NASH Day events, including an interactive map of all our partner activities and events, can be found at globalliver.org. So with that, I will wish you stay safe, be well, and please share what you've learned here today. Thank you.